Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Eran Maman from Tel Aviv, Israel. Eran was appointed at Tel Aviv Medical Center as head of the shoulder unit in 2010 after he finished the fellowships at Toronto Mount Sinai Orthopaedic and Arthritic Institute. His primary practice involves shoulder surgery. His research interests are clinical as well as basic science and shoulder pathologies and is the head of the laboratory for shoulder research. Dr. Maman is one of the early developers of the in-space balloon technique. Dr. Maman was the chairman of the Israeli Shoulder Society in the past as well. So today, it's my great honor to bring back Dr. Eran Maman from Tel Aviv, Israel. Over to you, Dr. Maman.
Good morning, afternoon, and evening to everybody. So today our topic is going to be about the hemiarthroplasty for young patients. So as we're well aware that osteoarthritis in young patients is really troubling issue. And what are the options today for those patients in 2020? So there is the prosthetic metallic implants, regular stem, short stem, no stem, pyrocarbon heads, or non-prosthetic resurfacing, like soft tissue graft on the glenoid side, osteochondral graft, etc. These options are comparable to the conventional total shoulder that we know, the anatomic total shoulder. So let's start with the anatomic total shoulder, see what the literature said about it. So this study of about 1,500 patients, no age limit, long follow-up, published in 2009. 15 years follow-up, as you can see, the survival rate is around 94, 89, 87. However, in the Caulfield 1 metal back, the results are not as good, and the revision rate is relatively high with only 67% of survival. If you go lower, because basically we're talking about younger patients, if you go lower to under the age of 60, you can see that the metal back glenoid component is starting to cause trouble at around 6.5 years, unlike the polyethylene, which relatively holds until 10 years, and then we can see that the deterioration and the revision rates is higher. What about the age of 55 and younger? This study was published 2013. 10 years follow-up, 50 shoulder anatomic total shoulder arthroplasty, 8 centers, 62.5% of survival. And the survival, they say that it was requiring revision for the glenoid. It means that there are some patients that are not as good, they are not happy, but they decline to have a surgery for replacing, for revision. So probably the results are even less than 62.5 if we look at the satisfaction rate of the patient. What about comparing the hemiarthroplasty versus anatomic total shoulder arthroplasty? So two systemic review, one of about 2,000 patients, 23 studies from 1996 to 2004, a follow-up of at least 43 months. We can see that in terms of pain relief, the anatomic total shoulder is better. Forward flexion, gain of forward flexion and external rotation, again, the anatomic total shoulder shows better result than the hemiarthroplasty. Patient satisfaction, again, the total shoulder is much better than hemiarthroplasty. Let's go for another systemic review. 2011 patient, 2,111 shoulders, 18 studies. The revision rate on hemiarthroplasty was higher, significantly higher than the anatomic total shoulder, 13% versus 7%. Complication rate, anatomic total shoulder had 12% of complication rate, unlike the hemiarthroplasty, which was only 8%. What about the age of 60 and younger? Neton from Lyon, France, 202 anatomic total shoulder at relatively young patient, 55, comparing to 31 hemiarthroplasty, again, young patient. In 20 years follow-up, the anatomic total shoulder, mostly because of glenoid losing, the implant survival rate was only 60. It's not good. 20 years, only 60% survival rate. Hemiarthroplasty were better. At more than 10 years, but less than 20, it was 79% of survival rate. However, they concluded that the total shoulder arthroplasty was significantly better in functional and subjective outcomes. Another study of the age of 55 and younger, okay, in this case, 46 total shoulder, 20 hemiarthroplasty for up 7 years, implant survival rate, which means revision at 10 years, 92% of anatomic total shoulder, unlike 72% of hemiarthroplasty. Look at the difference. Again, pain, active forward flexion, satisfaction rate were much better than total shoulder. And these results, as I conclude, were favorable for total shoulder arthroplasty in terms of pain relief, motion, and implant survival. So if the patient is younger, and probably the anatomic total shoulder will do better according to this study. Let's go to even younger population, 50 and younger. 71 patient, third generation stem, 5-year implant survival rate, and the total shoulder was 95, hemiarthroplasty 89. It wasn't significant. However, patient satisfaction 95 in favor, 95% versus 71.6 the hemiarthroplasty. So, of course, in this study as well, you can see that the total shoulder is better in terms of function and satisfaction rate. However, they could not understand why the difference in patient satisfaction for implant survival was not going accordingly. So let's focus on hemiarthroplasty only. This study, 272 patient hemiarthroplasty, 10 years implant survival rate and consent score. So you can see overall, the 10-year survival rate was 88.1%, which is pretty good. If we look at the reason for doing the surgery, rheumatoid arthritis, AVN, osteoarthritis were the best. 100, 94%, 94% for those indications. Consent score, the best were for AVN, 70, and osteoarthritis, 60.7. So primary glenohumeral osteoarthritis and AVN were the best indication for patients under the age of 50. NIST Multicenter Study 2018. This is the first series they published, 490 hemiarthroplasty metal head. Okay, the mean age was 49, and the main indication were fractures, 27% fracture sequela 25%. So overall, around 50% because of fracture or fracture sequela. And the 10-year survival rate was around 85%, which is not bad. If the patient were older than 50, it raised to 89%. If they were younger than 50, it dropped to 78%. However, they had 11% of revision. Because of pain from glenoid, it was 9.5%. So again, the glenoid, that's the main problem in anatomic total shoulder. Otherwise, the results are much better. And why is that? Well, because you can see here that the model of elasticity. The model of elasticity of the bone is around 18 to 17. Cobalt chrome around 200, 240, which means we have a very strong humeral head against a very soft or weak glenoid. So people try to think of other options, as you can see here, try to do hemiarthroplasty with some biological resurfacing of the glenoid. This group were coming from Texas, Butch Krishnan, 36 shoulders, 1988 to 2003. They did hemiarthroplasty with all sort of biological glenoid resurfacing. They tried anterior capsule, which were poor result. Fascia lata, Achilles tendon was, according to their study, the most recommended. It's even provide pain relief similar to total shoulder. Nearly the same group from 2004 to 2011. This time they used acellular human dermal allograft with hemiarthroplasty, and the satisfaction rate was 81% for highly satisfied and satisfied, which is wonderful. However, other groups that try to do similar studies, like this group from that published in 2014, 45 patient, mean age 42. They use lateral meniscus allograft to human acellular dermal matrix. they had around 51% of failure, which is pretty high. And if you look at the lateral meniscus, it was 45, and the dermal matrix was 70% of failure. So overall, if we look at the hemiarthroplasty for glenohumeral joint arthritis with a combination of hemiarthroplasty and biological resurfacing, there is mixed opinion. And there's no level 1 study, and the progressive joint space narrowing glenoid erosion continue, although we use different methods. So the ideal humeral head surface is probably supposed to be anatomically sized, biocompatible, low friction, durable with minimal wear particle, and elasticity similar to the glenoid. So that's where the Pyrocarbon options came to the one of the solution that resolved this problem. And the reason that was behind it, that it works on a smaller joint. So maybe it will work on the shoulder as well. And why Pyrocarbon? We can see again, if you go to the model of elasticity, the bone model of elasticity, again, it's 11 to 17. And the Pyrocarbon is 25 to 30. It's much better than the cobalt chrome that we talked about earlier that has model of elasticity of 200 to 240. So it makes sense that we use material that is similar to the bone, there will be less erosion to the glenoid. So is it so? This is a study that compare the polyethylene on bone on the left, as you can see here. And you can see the stress around the polyethylene is much higher than the bone because the difference of model of elasticity. If we go to the right, that's ceramic on bone. Again, this time the ceramic is stiffer than the bone, and it causes stress on the bone much higher than the ceramic. But if you go to the Pyrocarbon, you can see that it's very similar, and the stress is equal from both sides of the joint. So the Nice multi-center study, that's the second series, 40 hemiarthroplasty with Pyrocarbon head under the age of 60 and younger. So the mean age was 48, previous surgery or in 60% of the patient. Again, fracture sequela, 11 patient, AVN, 6 patient, osteoarthritis, 10. And the implant survival rate at 3 years was 91.3%, with 8% of revision. Now, remember the previous study of this group on metalhead, they had 11% of revisions with 9.5 because of glenoid erosions. So what they conclude that the Pyrocarbon is not seen to prevent the glenoid erosion and the revision rate because the results were similar to their previous study. However, other group from France, 61 patients, used Pyrocarbon head in 5 centers. Mean age was 57.9, and the follow-up was at least or more than 2 years. Again, osteoarthritis in 37 patients, secondary osteoarthritis in 11, AVN in 11, no fracture as you can see. And these are the results with the CONSA score points. So you can see that the points and scores that people gain out of after the surgery was mostly around 40 to 50 points, which is wonderful, except for two group that has secondary osteoarthritis because of fracture. Again, the fracture is the issue, and osteonecrosis after fracture. So if fracture involved in any way, even if it's not the acute phase fracture, it's a long period fracture, the results are not as good. But what is very interesting in this study that you can see that even type B1 and type B2 glenoid, according to Walsh, has a very good CONSA score eventually. At the end of the study, 78 and 77 points, its CONSA score, it's quite good for those patients with B1 and B2, which we usually don't do hemiarthroplasty for this patient. And what they actually saw that in 86%, there were no progression of the glenoid erosion. 14% was only slightly devolved. Some type B glenoid had recenter and remodeling with a very good improvement in CONSA score. Primary osteoarthritis, B1, B2, were very, very good. In some, even B1 and B2, the improvement were quite significant and very, very surprising. So they conclude for the young patient that B1 glenoid with pyrocarbon head and osteoarthritis is acceptable option. And even in some cases of B2, which we usually said, okay, we're not going to go for anatomic option. I'm aware of a study going now in the United States, but I don't have the result. To the best of my knowledge, they haven't been published yet, but it will be very, very interesting because they talk about 157 patients of 2 or more years follow-up with a pyrocarbon head, so it's supposed to be very, very interesting. So if you conclude the subject of hemiarthroplasty for glenohumeral arthritis in a young patient, it's clear that the anatomic total shoulder for this patient has a lower survival rate as the age is younger and as the follow-up is exceeding 10 years. Anatomic total shoulder is better than hemiarthroplasty in terms of pain relief, range of motion, and satisfaction. However, hemiarthroplasty is better than the anatomic total shoulder if we're talking about more than 10 to 15 years survival. The best indication for hemiarthroplasty is osteoarthritis and AVN. And the option of a hemiarthroplasty with glenoid biological resurfacing has mixed results, some as you saw with 80% of success and some with very poor result. What about the pyrocarbon head? Again, the results are mixed if you compare the NIST group, the second NIST group, and the studies that are done by Jerome. So if I have a patient with osteoarthritis, he's young, he's active. So again, the longevity of the shoulder arthroplasty is still a concern. I probably won't go for anatomic at the young age patient. I'll start if it's a very mild osteoarthritis. I'll go for debridement, capsular release, osteophyte removal, CAM procedure, etc. And if it's advanced, I'll probably go for hemiarthroplasty with short stem, pyrocarbon head, and glenoid reaming if necessary. However, if the patient will say, I want the best result, even if it's only for 5 or 10 years, then probably total shoulder will give us the best result for the short period of time. Thank you very much.
Thank you, Dr. Maman, for yet another brilliant presentation. And we're glad to see so much of experience from yours, and that's going to contribute so much for this lecture. Just a few questions. What is your experience on the ream and run technique, which was popularized by Frederick Mattson from Seattle?
Well, that's one of the options, especially when the problem is on the glenoid side. In most cases, I find that the problem is only in the humeral side, and then I do the pyrocarbon or resect some osteophyte if necessary. But if the problem, you know about the entity of problem on the glenoid side, yes, then we should consider the rim and run. I'm a bit confused now with the result of the pyrocarbon that showed that there is some remodeling of B1 and B2, because these are the cases that we say, okay, you know what, I have to go for reverse, but he's a very young patient. I'm not keen of having a reverse for young patient, but if I do only hemiarthroplasty, it will go to the back and will probably continue the B2 involvement. However, seeing those results on B1 and B2 makes me wonder, maybe even in those cases, I will go for the hemi with pyrocarbon, and hopefully there will be a remodeling of the glenoid component.
Thank you, Dr. Maman, for that. And what is the experience regarding shoulder resurfacing? Like, there's a lot of talk about the hemi cap, just resurface the humeral head.
Well, I did it in the past. My results weren't as good. Usually there's a problem of overstuffing. It's very hard to evaluate exactly how much you have to resurface and what the size of the implant is going to be. But now when we have the short stems and no stems prosthesis, probably I think it's the results are more, in my hand at least, more safe and more predictable than going for the resurfacing.
Thank you, Dr. Maman. And do you think there's a difference when you do a hemiarthroplasty for a arthritis versus a fracture?
Yes, well, all the studies that I've shown, the results, so if the fracture was involved, the results were poorer, definitely. Even if there's a fracture sequela, AVN, a fresh fracture, the results are not as good. So when there's a fracture, you should consider twice whether you go for any kind of anatomic or hemiarthroplasty. If the patient is young, that's an issue. If the patient is old, go for the reverse for sure.
The problem is that younger 35 to 55 age group, isn't it? When you have a fracture.
Exactly. Now I'm doing the pyrocarbon head for humeral fracture at that ages. Age 35, 55, when there's no options for osteosynthesis, I'll do a hemi. I use the pyrocarbon head. It's off-label indication for the company that manufactures the pyrocarbon because the stem is not meant for a fracture. But if you use the longer stem with a cement, it can work as long as the fracture doesn't go to the metaphysis. And I must say that the results are surprisingly good. I've done around 6 or 7 cases, and I was really impressed by the patients. Not all, of course, but they're much better than the other hemi that I used to do. So I'm not sure whether it's because of the head or just because I get lucky. I don't know, but so far that's what I'm doing for this kind of age.
Thank you, Dr. Maman. Just one last question before we conclude. Now, suppose the hemiarthroplasty fails for some reason. I mean, you said that there's a 8% revision rate. So what are the options? Is it a reverse or a total shoulder?
Depends on the age. If the patient is young, I will go for anatomic total. Okay, I'll try, and let's presume, of course, that my impression that the glenoid side, that's the problem with the erosions and painful glenoid. If the patient is older, I switch to reverse. You know, there are people now that are doing reverse for any kind of osteoarthritis and don't even deal with the anatomics. I'm not sure it's the correct. I think that the anatomic gives us still better results. But if the patient is young and is working and is very active, I'll go for anatomic. But he should be aware that probably after several years, he might have to have a third surgery for a reverse.
And can we just make a statement that the reverse should be only a last option and to be reserved for elderly patients?
Sorry, again?
Can we make a statement that the reverse shoulder arthroplasty should be reserved for the elderly patients, those who are above 65 or 70?
Yeah, I would say yes. I would say it's probably right. But you know, when you do surgery and you feel comfortable with it, you start to broaden the indication. So people start to doing a lot of stuff that we didn't even thought about it 10 years ago. So the statement is right for now. What's going to be tomorrow, I'm not sure.
Okay. Thank you, Dr. Maman. I think that's all the questions that we have. Thank you once again for joining. And that was a fantastic session, a lot of new insight, and your experience really added to this fantastic lecture. Thank you once again.
Thank you very much.